Very good morning to all. So I'll be speaking on, so when you come to manage pediatric cataracts, everything from decision making becomes a challenge. So the next challenge probably what we face, all of us, when we decide to put IOL is what calculation, how do you calculate the power? So what are the challenges? Why do we have challenges? Obviously because of the age of the child. The younger the age, the more the difficulty. DBR surprises are always, you have to keep in mind. Myopic shift you have to take into account. Corneal diameter and the steepness has an issue. Axial length of the patient and laterality of the cataract decides how early you decide to operate, how much anisometropia you can afford, and visual rehabilitation. So all this gives you the challenge when you decide how to calculate the IOL power. So what are the factors which influence IOL calculation in children? So these are the things: what formula to use, and myopic shift, amount of shift depending on the age, how to calculate axial length in keratometry, and the target refraction. So these are the factors which influence calculation for IOL. So IOL calculation, there are two things: partial coherence interferometry and IOL master, Carl-Zeiss and Lanstra. So the limitations is very young children who are not cooperative and very dense cataract. This method is difficult. So keratometry, how do we calculate? So very cooperative children above 3 years, 3 to 4 years, many children cooperate for regular manual keratometer. More reliable because of fixation is better. If fixation is better, it's more reliable. But very often we may have to resort to a technique under anesthesia where infants and uncooperative children, like less than 3 years, 4 years, sometimes you may have to resort to this. So this is handheld keratometer, may be unreliable due to poor centration because there is no fixation here. And biometry, applanation E-scan biometry is the most used. It is soft, flexible for the pediatric eye. Measurement artifact can come. Immersion E-scan biometry is more accurate, and limitations in small globes and anterior chambers may be an issue in this method. So IOL calculation. So what are the formulas we use? Derived from various studies based on adult eyes, sometimes are unpredictable when you just manipulate in children. Regression formulas, the commonest, all the 5, SRK, SRK2, theoretical formulas like Holiday 1, Hoffer Q, SRKT, all the 5, according to some studies, have similar but unsatisfactory results. In this particular study, they used all the 4 and compared. The mean predictability was comparable, and younger children in shorter axial length, Hoffer Q seemed to have better predictable results. So it's always still a contradiction, like which table is really standard. So SRK2, Hoffer Q, SRKT, all of them can be used in children. So it is the target refraction now next. After you choose the formula, then you need to decide what power to take. So there is a rough rule of 7 for above 2 years children, like age plus target hyperopia should be 7. So for example, if a 2-year-old child you plan, then plus 5 diopter you keep as target refraction, so that you have 7 as the number. And there is another method where most of us follow. Age 2 to 4 IOL power is equal to the spherical equivalent of the fellow eye minus 1.5. This is very rarely used based on the next other eye. IOL power more than 4 years, spherical equivalent of the fellow eye. This method is really not really used. So nowadays we talk about children and infants getting IOL implantation. So less than 6 months, which is very, very rarely we put IOL, but in such cases, moderate hyperopia you can aim for more than 3 diopters to 7 diopters. 12 months children, mild hyperopia, 0 to 3 diopters. This is according to Wilson's study. 4 to 6 weeks, very rare IOL implantation. This is not supposed to convey that you can put IOL in such young eyes, but 8 diopters is supposed to be the target refraction, and 6 weeks to 6 months, 6 diopters. This is based on infant aphakia study. So age, what we follow is commonly age above 4 years, undercorrect by 10%, 2 to 4 years undercorrect by 10%, and less than 2 years by 20%. So according to IATS, where we put children less than 1 year IOL, so this study says large predictive errors for prospective children, like 41% were within 1% of target refraction. So the predictability is good. The greatest prediction error was seen in children less than 18 months. Like nowadays, when we plan IOL in less than 1 year children, we plan to avoid children with axial lengths less than 16 or so. So probably we shouldn't face problems if we plan what children you can put IOL even if they are less than 6 months to 1 year age. So you have to base on the corneal diameter and axial length. It has to be above 16 millimeters. So then after you calculate IOL, like what is the choice? Calculate IOL power. What is the choice of the IOL which is suited? So single or multi-piece PMMA lenses, these are the options like hyperphobic acrylic single piece in the bag, hydrophobic acrylic 3-piece in the sulcus if you need to put in the sulcus. Safe to use because optical diameter should be 10.5 to 12 millimeters. So challenges when it comes to trauma, what do we face? Like this is never an option nowadays. Because of the corneal scar, if you have clear Myers despite corneal scar, manual K as any other patient, distorted Myers or very distorted Myers. You may face all these three situations. So manual K if the Myers are clear, topo sim K if Myers are distorted, but you can still get away with it. Very distorted Myers, you can use standard K, which is very rarely done. So this is how a distorted Meyer can look. So IOL power calculation take home is fellow eye K method. In trauma this is, fellow eye K method is not at all a good option. Topo sim K can be used in most of the situations, and plan DBR after suture removal when you can rely upon the calculation of K. And contact lens trial prior to planning secondary IOL implantation can be a good option. So is it over after you calculate IOL and plan what to put? I think the next speakers will be brushing on this. But surgery is only the first step. I keep telling the patients, parents, everybody that surgery is only the first step when you come to manage pediatric cataracts. So you need to give appropriate glasses, taking into account the target retinoscopy that you had aimed for. So all children, infants, even if they are pseudophakic, glasses have to be prescribed as early as possible, along with the near correction depending on the age. And aphakia management, lensectomy with anterior vitrectomy if you have done. Bilateral aphakic glasses less than 2 years and bifocals beyond 2 years. This is for glasses. Contact lenses theoretically may prevent nystagmus if nystagmus is not there. May be a good option even in bilateral cataracts. Secondary IOL implantation as soon as maybe above 4 years, 5 years of age. Before school going age, we recommend secondary IOL implantation. If it's unilateral, contact lenses is the first option. RGP extended wear lenses, difficult to insert but better option. And glasses in very, very uncooperative children or remaining time when the contact lens is not being used. And secondary IOL, you can use it early, like at 2 years of age, you can put secondary IOL implantation. So there may be other scopes like adjustable IOLs, newer IOLs like multifocal IOLs. These are all very, very, very preliminary for children when you take it into account. So to conclude, Emerson A-scan biometry is more reliable due to axial length measurements or more reliable for children for IOL calculations. All available formulas may have predictive errors in shorter eyes. So when you plan for shorter eyes, you have to think about this. Low degree of postoperative hyperopia does not adversely result in long-term visual acuity, so you have to aim for it. Preoperative counseling is very important regarding spectacle wear. This is very important. And thank you.